By the time you finish watching this video, approximately 20 seniors somewhere in this country will receive a dementia diagnosis. That is one person every 66 seconds. But here's the question that has been sitting with me for a long time. What if the root cause in many of those cases is not simply getting older? What if it is sitting right there in the medicine cabinet? A 2015 study published in JAMA Internal Medicine followed nearly 3,500 adults aged 65 and older for an average of 7 years. Researchers found that people taking certain commonly prescribed medications had up to a 54% higher risk of developing dementia. That is more than half again the baseline risk from medications dispensed every single day without those conversations ever happening. In the next 14 minutes, I am going to walk you through the 9 most important medication categories linked to accelerated cognitive decline in older adults. I will show you exactly what these drugs do inside the aging brain, why the risk compounds over time, and what safer alternatives exist right now. After more than 2 decades working in medicine, I believe you deserve this information before something goes wrong, not after. Before we go further, drop a comment right now with the names of any medications you take daily. I want to see what is in your medicine cabinet because what I am about to share applies very differently depending on which specific drugs you are taking and for how long. Several of these categories interact with each other in ways that multiply the risk significantly. And if you have ever noticed your thinking feels slower or your memory feels less reliable after starting a new medication, add the word foggy to your comment. That detail matters and you will understand exactly why in about 4 minutes. Here is a scenario that plays out thousands of times every single day. A 74-year-old goes to the doctor for 3 separate problems: trouble sleeping, bladder urgency, and mild chronic anxiety. 3 separate appointments, 3 separate prescriptions, each one reasonable on its own. 6 months later, her family notices she repeats herself in conversation. She forgets appointments. She misplaces things. A neurologist is consulted. The family begins preparing for Alzheimer's disease. Nobody connects the medications to the decline. Nobody looks at the 3 prescriptions together and calculates what they are doing to the brain in combination. The medications continue, the decline continues. This scenario is not rare. Research examining prescription practices and cognitive outcomes has consistently found that physicians are prescribing medications whose individual cognitive risks are known, but whose combined burden is rarely calculated. Most patients are never told. The gap between what the published evidence shows and what happens in a 15-minute appointment is costing people something they cannot get back. Now, if you are someone who values understanding the why, not just being told what to do, then what I am about to explain will give you a completely different framework for thinking about medications and brain health as you age. Your brain at 75 is not simply an older version of your brain at 45. 3 fundamental changes make it far more vulnerable to certain medications. First, acetylcholine production declines. This neurotransmitter is the one most directly responsible for forming new memories. An aging brain has less to work with, like a phone battery that no longer holds a full charge. When a medication then blocks acetylcholine further, you are cutting into a supply that already has no reserve. Second, the blood-brain barrier becomes more permeable with age. Many medications that once stayed largely outside the brain now cross more freely into brain tissue and clear more slowly because aging kidneys and liver process them less efficiently. Third, the brain's repair capacity slows, neuroplasticity declines. When a younger brain is chemically disrupted for months, it can often recover when the disruption stops. An older brain, under the same pressure, may sustain damage that is permanent if the exposure continues long enough. These are not small differences. They are fundamental changes that demand a completely different approach, and yet the prescribing guidelines most doctors follow were written without fully accounting for them. Number 9 is diphenhydramine, sold as Benadryl and found in virtually every PM-labeled sleep or pain product. You reach for it when you cannot sleep or when allergies flare. It is available at any checkout counter. Most people have never considered it a medication that requires monitoring. Diphenhydramine is an anticholinergic. It works by blocking acetylcholine throughout the nervous system. In your nose, that reduces swelling. But the drug travels everywhere your bloodstream goes, including the hippocampus, where acetylcholine is critical for converting experiences into lasting memories. Think of it like a power surge that keeps interrupting a recording studio. Some of what gets recorded comes out garbled. Some does not record at all. With repeated interruptions over years, the equipment itself begins to degrade. The 2015 JAMA Internal Medicine study, 3,434 adults aged 65 and older, followed 7 years, found that the highest cumulative anticholinergic users users had a 54% increased risk of developing dementia compared to non-users. The fix: check every PM or nighttime product label for diphenhydramine. For allergies, second-generation antihistamines like loratadine or cetirizine do not cross the blood-brain barrier to the same degree and are substantially safer for regular use in older adults. For sleep, melatonin at low doses or a conversation about non-anticholinergic options is a far better starting point. Number 8 is proton pump inhibitors, omeprazole, pantoprazole, esomeprazole. And this one is marketed specifically as something that protects your stomach. You take one every morning, the acid reflux disappeared. Your doctor said it was safe long term. That was years ago. You have not questioned it since. The problem is that stomach acid is not only there to cause discomfort, it is essential infrastructure for absorbing vitamin B12 and magnesium, both critical for healthy brain function. Think of stomach acid as the loading dock of a warehouse. When the dock is suppressed long term, B12 and magnesium deliveries go unprocessed. The neurons that depend on B12 to maintain their insulating sheath begin to degrade. The signals they carry start to misfire. A 2016 study published in JAMA Neurology examined data from 73,679 patients aged 75 and older. Regular PPI users had a 44% increased risk of dementia diagnosis compared to non-users. It is important to note that later studies produced mixed results and the causal relationship remains actively debated, but the nutrient depletion mechanism is well documented regardless. The fix: if you have taken a PPI for more than 6 months, ask your doctor to check your B12 and magnesium levels. Ask whether an H2 blocker like famotidine might manage your symptoms with a lower cognitive risk profile. Number 7 is oxybutynin, prescribed for overactive bladder. And this one reaches directly into your brain's memory centers with every dose. You were told it would reduce the urgency. It did. You were not told what else it does. Oxybutynin is a potent anticholinergic, far more aggressive than diphenhydramine in its ability to penetrate the blood-brain barrier and suppress acetylcholine inside the hippocampus. Think of the hippocampus as a photograph developing room. Acetylcholine is the chemical that sets the image permanently. When oxybutynin floods the room, new memories stop forming properly. Appointments get missed, names disappear mid-sentence, conversations end without the words that were supposed to come. A 2019 BMJ study examining data from 58,769 dementia patients and 225,574 matched controls found that strong anticholinergics, including oxybutynin used for more than 3 cumulative months, were significantly associated with increased dementia risk. The fix: ask your physician specifically about mirabegron, sold as Myrbetriq. This controls overactive bladder through a mechanism that does not block acetylcholine at all. Pelvic floor physical therapy has also been shown in randomized trials to reduce urgency without any cognitive pharmacological burden. Number 6 is certain statins, and this one is the most nuanced on this entire list because the cardiovascular benefit is real. And I am going to give you the full picture rather than a simple warning. Your brain is approximately 60% fat by dry weight. Cholesterol is not just a cardiovascular risk marker, it is a building material. The myelin sheath, the insulating coating around your nerve fibers, is partly composed of cholesterol. When certain statins cross the blood-brain barrier and suppress cholesterol synthesis inside brain tissue, they can interfere with myelin maintenance. Think of myelin as the rubber insulation on an electrical wire. When it thins, the current bleeds out and signals slow down or misfire. Research on statins and cognition has produced genuinely mixed results. Some studies show a protective effect, others suggest harm. A 2022 review published in Frontiers in Aging. Neuroscience found that lipophilic statins, those that dissolve in fat and penetrate brain tissue more readily, particularly simvastatin and atorvastatin at high doses, showed more consistent cognitive concerns in older adults than hydrophilic statins like pravastatin and rosuvastatin. The fix: do not stop your statin. If you are experiencing cognitive symptoms, fog, word-finding difficulty, memory lapses, have a specific conversation with your prescribing physician about whether hydrophilic statin at the lowest effective dose might preserve cardiovascular protection with a lower cognitive burden. That conversation is worth having explicitly. Number 5 is benzodiazepines, lorazepam, diazepam, alprazolam, Ativan, Valium, Xanax. And millions of people are completely trapped in these medications. The trap is chemical, not psychological. You were prescribed one for anxiety or sleep. That was 2 years ago. You are still taking it. Stopping feels impossible because it is if done abruptly. Benzodiazepines enhance GABA, the brain's primary inhibitory signal. Over weeks and months, the brain adapts by reducing its own GABA production. Now you need the medication just to feel baseline. Meanwhile, the drug dampens the neural firing required to consolidate memories. Think of it like a library where the filing staff is working at half speed. New books arrive daily. Nothing gets properly cataloged. You experience the moment, your brain simply cannot retrieve it. A 2014 BMJ case control study of more than 8,000 older adults found that benzodiazepine use for more than 3 months was associated with an approximately 51% increased risk of Alzheimer's disease. The risk was strongest for long-acting formulations that accumulate in brain tissue. The fix: do not stop suddenly. Benzodiazepine withdrawal can be medically dangerous. Work with your physician on a gradual taper protocol. Cognitive behavioral therapy for insomnia, known as CBTI, has been shown in multiple randomized trials to outperform medication for long-term sleep quality with no cognitive cost. Number 4 is amitriptyline, sold as Elovil, and this one is prescribed for pain, not anxiety, which means far fewer people suspect it. It was prescribed for nerve pain, chronic headaches, or sleep. It works for those conditions. The prescribing physician almost certainly did not flag it as one of the most potent anticholinergic medications still in widespread clinical use, because they are thinking of it as a pain tool, not a memory threat. Low dose, taken nightly over years, that exact pattern produces the most insidious cognitive damage. Not because any single dose is catastrophic, but because cumulative acetylcholine blockade in a brain already producing less of it creates an erosion that looks exactly like early dementia. Think of it like a slow water leak under a floorboard. Any single day, the damage is invisible. Over 3 years, the structural integrity is gone. The same 2015 JAMA Internal Medicine study, 3,434 adults, 7 years of follow-up, specifically identified tricyclic antidepressants like amitriptyline as among the highest burden agents with a 54% greater dementia risk at the highest cumulative exposure levels. The American Geriatric Society includes amitriptyline on its Beers criteria as potentially inappropriate for older adults. The fix for neuropathic pain, duloxetine, and gabapentin offer alternatives without the same anticholinergic burden. For sleep, low-dose doxepin carries a substantially milder anticholinergic profile. For mood, sertraline or schizoprolol are consistently classified as safer options for older adults. Number 3 is paroxetine, sold as Paxil, and this one is prescribed as an antidepressant, so most people assume it is one of the safer options. That assumption is wrong for one specific reason. Paroxetine belongs to the SSRI class, the modern generation of antidepressants. Most SSRIs are genuinely safer for the aging brain. Paroxetine is the exception. It is the only SSRI with substantial anticholinergic properties, and that one difference changes everything about its risk profile in older adults. Think of the SSRI class as a family of medications where every member drives safely except one, who quietly runs stop signs. From the outside, they all look the same. The difference only becomes visible in the pattern of outcomes over time. A 2021 review published in Frontiers in Psychiatry found that paroxetine users showed measurable declines in short-term memory and verbal recall within 12 months of treatment, effects that were not seen with other SSRIs. The American Geriatric Society lists paroxetine specifically on its Beers criteria, recommending it be avoided in older adults when alternatives exist. The fix: if you are taking paroxetine, ask your physician specifically about transitioning to sertraline or escitalopram. Both treat the same conditions effectively and carry consistently better cognitive safety profiles for older adults. Number 2 is antipsychotics, quetiapine, risperidone, olanzapine, and this one is especially alarming because it is happening in care settings where it should never be happening, with drugs that were never intended for the patients now receiving them. These medications were developed for severe psychiatric illness. They have a legitimate role in schizophrenia and bipolar disorder. What they do not have is a legitimate role as routine management tools for older adults who are confused or restless in nursing facilities. Yet that is precisely how they are increasingly used. Antipsychotics suppress dopamine, the neurotransmitter that drives motivation, executive function, and memory-based learning. When dopamine signaling collapses in an aging brain, processing slows dramatically, personality flattens. The person who was difficult to manage is now quiet. Family members interpret this as the disease progressing. In many cases, it is the medication acting. A 2024 BMJ study drawing on over 173,000 older adults with new dementia diagnoses in the United Kingdom found that antipsychotic use was associated with substantially increased risks of stroke, pneumonia, and accelerated cognitive decline, with the highest risks appearing in the first weeks of treatment treatment. The FDA has issued a black box warning on antipsychotic use in older adults with dementia-related psychosis. The fix: if a loved one in a care setting has been prescribed an antipsychotic, ask directly, what behavioral target is this treating? Has non-pharmacological management been attempted? What is the plan for reassessment and discontinuation? Those questions are your right. Structured daily routines, reduced sensory overstimulation, and adequate pain assessment have strong evidence for reducing agitation without pharmacological cognitive cost. Number one is anticholinergic polypharmacy. And this is not about any single drug. It is the hidden cumulative brain burden of taking multiple medications simultaneously, each of which blocks acetylcholine to some degree. Here is the scenario that concerns me most. A 72-year-old takes diphenhydramine nightly for sleep, oxybutynin for bladder control, amitriptyline at low dose for nerve pain. Each medication reviewed individually might receive a pass from a physician not specifically calculating cognitive burden. Together, they represent a multi-directional assault on the one neurotransmitter the aging brain can least afford to lose. When acetylcholine is blocked simultaneously from multiple angles, the effect is not simply additive, it is compounding. The brain enters a sustained state of reduced neural firing that on cognitive testing is very difficult to distinguish from Alzheimer's disease, because at a certain point, it is functionally indistinguishable from it. The 2019 JAMA Internal Medicine study examining 58,769 patients diagnosed with dementia and 225,574 matched controls found that high cumulative anticholinergic exposure was significantly associated with dementia risk. And critically, the risk was measurable even for medications taken years before clinical symptoms appeared. The damage accumulates long before anyone notices it. Drug-induced cognitive impairment, when identified early and the responsible medications reduced or changed, can be substantially reversible. The brain can recover, but it needs the burden lifted first. And that requires someone calculating the total first. Be completely honest right now. Do you know your total anticholinergic medication burden? Comment never checked below, because that answer tells me exactly how necessary this video was for you. The fix: ask your physician or pharmacist to calculate your anticholinergic burden score. Using your complete medication list, including every over-the-counter product, the Anticholinergic Cognitive Burden Scale is a validated tool that assigns numerical scores to individual medications. This is not about removing necessary medications. It is about knowing what you are carrying and whether there are lighter alternatives. If you have been taking one or more of these medications for years, or recognizing someone you love in these descriptions, hear this before you do anything else. It is not your fault. You were not given this information. Prescriptions are written in 15-minute appointments where cognitive burden scoring is almost never discussed. You trusted the process. That was entirely reasonable. And here is what I have seen consistently throughout my years in medicine. The human brain has a genuine capacity for recovery when the source of the damage is removed. Acetylcholine suppression can lift. Nutrient deficiencies caused by medication can be corrected. Neural pathways that have been running below capacity can rebuild. What we are discussing today is not a verdict, it is a starting point. Here is what you now understand that most people, including many healthcare providers, have not considered. Together, acetylcholine is not optional for memory. It is structural, and anything that blocks it in an aging brain carries real risk. The word common does not mean safe. Individual drug reviews miss the most important question. What is the combined burden of everything being taken simultaneously? And critically, drug-induced cognitive decline can substantially improve when the medication burden is lifted. You are no longer a passive recipient of prescriptions. You are an informed person who can ask better questions and advocate for yourself in a system that does not always slow down enough to see you as an individual. That is not a small thing. That is the entire difference. Let me give you specific steps you can take starting tonight. First, write down every single substance you take: prescription medications, over-the-counter products, sleep aids, allergy pills, supplements. Everything in one place. That list is the first tool you need. Second, check every PM or nighttime product label for the ingredient diphenhydramine. If it is there, you now know what that means for your brain. Third, search the name of each medication on your list alongside the words anticholinergic burden score. Many medications have published scores on the Anticholinergic Cognitive Burden Scale, which is publicly available. Fourth, if you have been on a proton pump inhibitor for more than 6 months, ask your doctor at your next visit to check your B12 and magnesium levels. This is a simple blood test and can identify a silent deficiency before it becomes a clinical problem. Fifth, if you or a loved one is in a care setting and currently prescribed an antipsychotic, ask the care team one question: what behavioral symptom is this treating, and what is the plan for reassessment? And finally, have an informed conversation with your doctor. Bring your complete medication list. Ask directly, what is my total anticholinergic burden, and are there safer alternatives for any of these? You deserve a physician who treats that question as legitimate, because the published research says it is. Drop a comment right now with the word aware. If this gave you something real today, if it names something you have been noticing but could not place, I want to see that word. It tells me you are taking your brain health seriously. Now think of one specific person you love, someone who takes multiple medications and has never had this conversation. Send them this video right now. Not tomorrow, right now. That single action may be the most meaningful health decision you make today, not for yourself, but for them. Subscribe to this channel. My goal is straightforward: to give you honest, research-grounded health information before something goes wrong, not after. In my next video, I am going to address blood pressure targets for adults over 75, and the specific range that research now suggests may actually be dangerous when applied to older physiology. The findings surprised even me after all my years in medicine. You will not want to miss it. This video is for educational and informational purposes only. It is not intended as medical advice. Decisions about your medications must be made individually, based on your complete medical history and in consultation with a qualified healthcare provider. Never reduce, stop, or change any medication without first speaking with your physician. The research cited reflects published findings in peer-reviewed journals and should be used to inform conversations with your care team, not to replace them.